Hello, everyone. Happy Thursday. We have Dr. Linehan here. We're just starting to let people in. So I'm going to keep letting people in. We've got both the Facebook Live is up. We've got this up. Tonight is number 6. We have 6 more on this kind of weekly schedule. And then we're going to go to every other week as life gets back a little bit more to normal. I think that'll be a better pace for us, but this is nice because everyone's still kind of hunkered down at home. And these are always recorded on the Facebook website for the Women's Health and Wellness Institute. And they are also on the YouTube channel. So that if you want to share them with anyone or watch them, that's where they are. And I think we are about ready to go. Let me just keep admitting a couple more people and we'll go. So remember that if you have questions, you can always put them in the chat box. You can text me. You can put them in the comment section of the Facebook Live, and I will make sure that that Dr. Linehan gets to them hopefully before 7. That is our drop-off time. So welcome, Dr. Linehan. We're so happy to have you here. So Dr. Linehan's a urologist at St. John's, also in our Cancer Institute. So I always like to start because I think people don't really understand what all the specialties are or where you come from, if you come from medicine training or surgical training, and how many years after medical school you do. So can you just give us like a brief synopsis of that? And then also, what's your practices like? I think one of the first myths that we'll talk about is that only men see urologists. And although that's probably the majority of your patients, there are definitely reasons why women see urologists. So if you can just kind of give us a brief background of you, that would be awesome.
Sure. So I'm Jen Linehan. Nice to meet you all. Thanks for tuning in. I went to college and med school at University of Arizona, and I stayed on there for my surgical urology residence. So urologists by training are surgeons, and residency for urologists is about 6 years of surgical training. And then I came out to California, went to City of Hope for my fellowship and did 2 years of robotic surgery training. And a lot of my practice is cancer of the prostate, cancer of the bladder, cancer of the kidney. I really sort of specialize in cancer of the kidney. And then I did a 2-year fellowship at City of Hope. I stayed on with City of Hope for a while, and then I came out to St. John's in about 2015. But some of urology is surgery, and some of urology is stuff that you can do in the clinic. And I would say a lot of my practice is actually female patients, both for cancer and other urologic disorders. I see a lot of patients for urinary tract infections, bladder pain, blood in the urine, patients that have kidney stones, patients that have incontinence or leaking or difficulty voiding. And I would say probably most of my practice is about 65 to 70% women, and the rest is men. So I think that's kind of a synopsis of my practice.
Yeah, that's excellent. And how long have you been at St. John's?
I've been at St. John's since 2015, so that'll be 6 years coming up, 5 years coming up.
Excellent. We are so happy to have her. So so we have lots of questions. I definitely got a lot of emails and texts from people who had questions about all of this. It's super interesting to us as women, and I think it's one of the most important places to talk about the whole erectile dysfunction. But I think something really interesting to talk about in the beginning is kind of just the physiology of the penis. Starting in 2nd grade, we think there's a bone there. And there's all kinds of other myths about what actually causes an erection. How does it occur? So can you start with just
listen to Jen talk about
who is that? Is that Melanie?
Jen can talk about penis and erections.
I can get rid of it.
Melanie.
What?
Mute.
Oh, I'm not on mute? I'm sorry. Okay, Amir wants to listen.
All right. So can you give us the physiology of it?
Yeah. So when the patient usually comes in the office, one of the first things I find is that people do not understand how the penis works. And if you understand how the penis works and how men get erections, it'll help patients figure out sometimes what they need to do next. So I want you to think of the penis as two cylinders. There's two of these floppy cylinders, and when it's filled with
Will you
blood,
guys mute your phones, please? Thank you.
this penis is two cylinders, and when the cylinders fill with blood, they get firm, and that actually generates the erection. And the other thing that patients sometimes don't understand is that erection and orgasm are actually two different things and two different sets of nerves. So the nerves that help a man get erection so that the cylinders in the penis can fill with blood are very different from the nerves that actually create orgasm. And you can have an orgasm without having an erection. So the penis does not have to get hard in order to have an orgasm because there's two sets of nerves that control that.
Fascinating. Okay, so that's really good to hear, and it is interesting that it's two cylinders and they just fill with blood. So why do they get erectile dysfunction, and which of those nerve centers is that? Like, what are the things that we need to worry about when there isn't an erection?
So the penis normally fills with blood to bring fresh blood flow into the tissues and into the nerves of the penis, which is why men really often get nocturnal erections. And erections are actually often stimulated by touch or vibration. So that's why when, we think of guys in high school who are walking down the hallway, putting their books in front of their penis because it got hard, because any type of like stimulation or rubbing, the penis naturally is meant to get hard to bring fresh blood flow in it. That's why men wake up with nighttime erections and wake up with morning erections as well. The penis is just doing its normal thing, getting some fresh blood flow into it. It's not always a sexual thing in a sense. So that's sort of the physiology of the penis. Now, men essentially have erectile dysfunction in my mind for three reasons. One is physiologic. So something is happening to the arteries to the penis that are not allowing it to fill with blood. And those arteries opening up can either be that they're blocked or that the nerves aren't signaling properly. Now, what I tell patients when they have erectile dysfunction, the one thing I worry about is actually cardiac disease. Because if the small arteries that go to your penis are blocked, that also means the big arteries in your heart can be getting blocked. And sometimes one of the first signs of heart disease or cardiac blocked arteries is actually erectile dysfunction. So
meaning that the same plaques that are in the vessels that are giving blood to the heart are also in the blood vessels that are giving blood to the penis.
Right. So the things that cause plaque in your arteries, like hypertension, high cholesterol, high triglycerides, are the same things that can clog up the small arteries in your penis. So that's why I tell men to watch their diet and exercise if it's happening, because it may not just be the arteries in the penis, it can be the arteries in the heart as well. So back to erectile dysfunction. So that's the physiologic reason that men get erectile dysfunction. On the other side of that is the libido or the testosterone. So when the testosterone goes low, the libido starts to go down and the drive to have sex goes down. Now, those are more the nerves that have to do with orgasm, and they don't drive the erection to start, but they help the erection to be maintained. So often a man will come into my office and say, well, I can get the erection, but I just can't keep it going. And then I know that may have more to do with the drive and libido. And the third thing is your head, is your brain. Your brain does play a role in this. So if someone's under stress or duress or having issues at home or work or everything, I have to also rule out those things that could be affecting their drive and their ability to have erections in a sense. So I have to kind of figure out all those three things, and oftentimes they all work together. I also find that some men are aroused with the erection, meaning they really need the erection to stimulate their arousal. And other men get aroused and don't necessarily need to have the erection. So you have to work with the patient and really listen to them about what they need to try to figure out what's driving the dysfunction.
So do you do like a team approach to this? I mean, it's interesting, right? That there's the three different pieces. So if it's physiologic, do you have them get a cardiology workup when they come to you with this problem?
Not necessarily cardiology workup, but I do have them touch base with their primary care physician to check for diabetes, to check for high cholesterol, to check for high triglycerides. Because like I said, if the small arteries get blocked, so could the bigger ones. And the downside is that if the small arteries get blocked, we don't have a way to open those up. So eating right, exercising, staying away from high fat foods, like these are all good things to do to protect your penis. In fact, I always tell my husband when I first met him, I was like, red meat once a month, because I want your penis to work until we're 80. So
that's good. I love that. That's good advice. So the other question I have is, please, you guys, if you have questions, you can either put them in the chat or on the Facebook Live page, and then I'll feed them to Dr. Linehan. So you talked about the testosterone and when that goes down. Is that like estrogen and menopause? Like, what is the timeline of men's testosterone going down, and how do they follow that? How do you know that?
So pretty much with men, just like women, after really age 36, 40, the testosterone starts to go down slowly. And in some men, just like women, are very sensitive to the loss of the hormone. They lose their sex drive. They don't feel so good. They don't want to work out anymore. They gain weight. They have fatigue. They overall just don't feel well. I do have patients that do have lower testosterones and they feel fine, and their bodies are just less sensitive to the change in the testosterone into the hormones. But again, remember the testosterone is mostly responsible for the libido, not the erection. And that plays more of a part in maintaining the erection than it does in the creating the erection itself. There are about 7 different ways that a man can get an erection if he has erectile dysfunction. So most patients know the most common ones, all the pills, Cialis, Viagra, Levitra, Strattera. There's all these different oral pills that men can take to help get the erection. And the job of the oral medications is that they bind to a receptor to help open up the blood vessels so that the cylinders in the penis can fill with blood, because it's not happening normally. Now, if you have a patient that's had spinal surgery or spinal cord injury, they may not be getting the signaling from the nerves to open up those vessels, so that could be a problem. Or if some of the smaller vessels are blocked, you may need to recruit some larger vessels, which is what the medications help. So that's the most common thing that we can do to treat erectile dysfunction.
And I'm sorry, those both Cialis and Viagra?
Cialis, Viagra, Levitra, there's another one, Strattera. There's multiple different oral medications now that we have. And what's funny, and I don't think we all understand this very well, is even though they're really stimulating the same receptor, some meds work for some patients and some meds don't work for other patients.
So how long would someone try one and then say this isn't working before they would try another one?
So depending on the medication, for example, if I give a patient Viagra, I would say, look, you cannot eat 2 hours before you take the Viagra and an hour after the medication. So you really need to be on an empty stomach, and you shouldn't drink alcohol because it decreases the potency of the medication. So they should really be on an empty stomach. And then I will tell them, try the medication 6 times. If after 6 times nothing happens, then we'll probably try a different medication. Now, Cialis, which was originally called the weekender pill, is meant to be for 3 days. So that's the 20 milligram Cialis. So that medication you're meant to be able to eat with. So the patients can eat with that, and it's supposed to last them about 3 days through what would be like a weekend for erectile function. And again, I tell them to try it 6 times, and after 6 times it doesn't work, then we'll try something else.
So it lasts for 3 days, but it does the same thing by attaching to something in the blood vessels to keep them open.
Correct. To help them open so that the cylinders can fill with blood.
Excellent. Okay, so the medications is just one of the 7 ways to improve erection? Okay.
So there also is a tiny little capsule that a man can put into the tip of the penis, into the urethra. And I know when I describe that to patients, it sounds awful, but it works really well. And it's called Muse, M-U-S-E. It's a urethral suppository. It's a little tiny pill, and you have this tiny little applicator, and they put it down there, and it delivers the medications that are very similar to Viagra and Levitra and Cialis directly into the penis. So you get direct stimulation of those cylinders and the arteries going to the penis.
I'm sorry, where do you put it?
It's a urethral suppository.
So you put it inside, okay.
So
And
on
was
that
that
same
right
level,
before? Is that like, that's a timing, like right then?
yeah, so, if they're going to have intercourse, I would tell them, 45 minutes, sometimes even less than that, before you start, put it into the tip of the penis. And that will generate the erection. Now, I've been working with another company in town that's a compounding pharmacy that uses a lidocaine gel that has the same types of medication, and the patient actually puts the lidocaine jelly into the tip of the penis. Patients seem to like this better because it's a little bit more comfortable. It has some numbing effect in it. And again, the medication acts quickly and locally because it goes directly into the bloodstream through the lining of the urethra. And so they may get an erection within 20 minutes of using this. And so patients do like this urethral option that they can use to get erections. The next option up is a penis pump. And I know we always make fun of that and Austin Powers, but they work really well. And I do have patients that I will recommend using a medical grade, not something that they buy on Amazon, a medical grade penis pump. And then basically you put the penis in this sort of plastic, or sometimes it's a glass cylinder, and you pump up the penis. So you pull the blood into the cylinders instead of doing it with medication. It's negative pressure, which is why you want to get a medical grade one and not one on Amazon, because it knows when to stop the pressure. And then you put a little rubber band at the base of the penis to keep the blood in the cylinders. So, and I have used those for years with patients, especially patients that are recovering from prostatectomy surgeries. It works very well to bring fresh blood flow into the penis, help regenerate the tissues and the nerves. And especially if you have a couple, like a wife and a husband, this is something they could do together, or a husband and a husband. This is something that they can do together and use. It doesn't require medications. It doesn't require a pill. It has no side effects. And I think it's a really great option. So the next level up from that is you can actually do penile injections. We use teeny tiny needles, and you actually inject the medication directly into the penis. And when I first tell patients this, they're like, oh no, I don't think I can do that. But they get really great erections from it. So they actually bring the medicine to my office, and I show them how to do it. And when they do it, they're like, oh, well, that didn't hurt at all. And so it's a very tolerable way that gives them an erection sometimes within 10 minutes. It acts very locally, so they don't have some of the other side effects that the oral medications have. And they can use it every couple of days, and they keep the medicine in the refrigerator, but it is an injection into the penis. And the last level up from that is actually the implants. And there's two types of implants. There's one that we call a semi-rigid, meaning that it goes in and it's sort of already firm, and you can sort of fold it and bend it up and down as needed. And the other one is actually a pump. And the pump is to replace the cylinders. So at some point in time, you can't get blood flow to the cylinders. So the doctor goes in and puts new cylinders in the penis, and you actually have a reservoir in your belly that has saline in it. And when you want to, there's a little pump, and the cylinders fill with the saline. And then when you're done having sex or intercourse, then you release the saline from the cylinders, and the penis is flaccid again. So but that is really for patients who have exhausted all of the other options and still want to have erections. I have 90-year-old patients that we are still putting penile prosthesis in, so just because you're older does not mean you don't want to have sex. It's important to the end.
Excellent. I'm getting so many questions, not in the chat box, but on my phone. So you've answered a bunch of them. But so here's a good question about the thing that we all hear on the TV or the radio commercials about the sustained erection for 8 hours or more. Can you talk about that and which ones have that risk and what that is?
Yeah, so I mean, all of the methods of giving a man an erection, the pills, the urethral suppository, the jelly, and the injections all have the risk of what we call priapism, which is a sustained erection. Now, really, if the blood gets into the penis, into the cylinders, and it stays in the cylinders over 4 hours, it's not fresh blood anymore. And the tissues in the penis are not getting fresh blood, and it starts to get clotted in there. And that is really what a priapism is. And so in those, and it usually is very painful. And so the patients will usually come into the ER. So I know, I've had some patients, they're like, why wouldn't I want to have an erection for 12 hours? That sounds like the greatest thing ever. No, not the greatest thing ever, because again, the blood is getting in and it's getting stuck in there, and the penis isn't getting fresh blood flow anymore. So you do have to be careful with those medications. Americans love to think more is better. More is not better in this situation.
So you're saying it's taking too much of something, or not starting with small enough doses to figure out what your tolerance is for it.
Right. And that's often what will happen. The patients that I generally see with priapism have taken either too many pills, or they've combined methods. They've done a shot and taken pills and that kind of thing. But so if you have a painful erection over 4 hours, you need to come to the ER right away.
That's great. So there was another question about, so can you talk about this in female physiology, and are any of those same pills, medications used in women, either off-label or on-label?
So they did do several trials with Viagra and I think some Cialis to enhance arousal in women. Although when they actually did the randomized studies, it didn't seem to change much. But again, I mean, the synonymous organ in women to the penis is the clitoris. The clitoris does get stimulated by touch, just like the penis does, except our penis isn't sticking out, our penis is hidden under the labia in our vagina. So in some women, it is used to make the clitoris more sensitive to stimulation, but there's no FDA really push or approval for it. But just like women, the clitoris gets in a sense erect and sensitive by different nerves than a woman has with an orgasm. So
this is just, those medications are just blood flow. They're not.
Yeah, they did, and in the study, it didn't actually prove to be that they would improve female sexual satisfaction. They did improve blood flow, and the clitoris did get more erect, but it didn't. When they did the quality studies, it didn't actually help the females with sexual function. And a lot of times women, the same thing for us, our hormones start to dwindle. We're less interested in sex. And I often counsel couples, both the men and the women, on those things, because if he's really interested in sex and she's not, it's not going to be a great experience for either of them. So
interesting. Okay, so I've got a couple of other questions. So there was one, so you talked about the 3 reasons: the physiologic, libido, and the brain. So if your man has erectile dysfunction, how do you go through this list of 3, and how would you counsel a girlfriend to okay, this is where you should start and this is how you should talk about it? How do you do that?
Well, the first thing you start out with is you do like the hormone assessment, and you do the physiological assessment.
Okay, wait, back up. How are you talking to your man about this? Oh, see, now I took you out of the doctor.
How are you getting your man to go to the doctor?
Yeah. So what do you actually say? How do you explain this and be like, okay, look, I think I listened to Dr. Linehan the other night, and she said, how talk me through that. How does that work?
So you talk to your man and be like, look, I noticed that there's some issues going on, and Dr. Linehan said that if your small arteries get blocked, it could be your big arteries, and you probably should go have an evaluation and talk to someone and just make sure that it's not representative of something else. There are rare occasions when erectile dysfunction is associated with prostate cancer. Very rarely do you see it as a direct cause of prostate cancer until it's very late stage, but it is something that we do like to work up. And you can do that simply with a blood test called PSA, which is the blood test for prostate cancer. So I think those are all reasons, if your guy has erectile dysfunction, say, hey, let's just go make sure you don't have, your PSA is normal and your arteries are good and open and everything's fine.
That's excellent. And then where in the workup, so that's kind of the physiologic part. Then, so is that the first thing that you kind of look at, and then you look at libido and then brain, or how would you do that?
I mean, it depends. Again, you have to listen to the patient and what they're telling you. If they're saying, I can get an erection, it's fine, I get the erection easily, but then I really can't maintain the erection, this is more a hormone problem. But if you do the whole, you do the whole workup anyway, meaning you look at the hormones, you look at the cholesterol, you look at the triglycerides, you look at, you check for diabetes, you look for all those things as causes. And if the patient's telling me that they're not maintaining the erection, then I'm starting to think that it might be something more with hormones or drive. And sometimes it's also mental. Are you having a lot of stress? Is something else going on? I will often have at least 5 times a year a 26-year-old kid walk into my office and be like, I can't get an erection anymore. And most of these guys, it's not physiologic, it's not hormonal, it is all in their heads. And sometimes I will just give them a couple doses of Cialis or Viagra to just get them back on track so that they can see, okay, my penis works, I'm totally fine. They get stage fright. They get nervous about, am I going to get the erection? And once they get that in their heads, they can't get over it. So sometimes I'll just give them something to help get over the hump. And that's the kind of mental stuff that I mean. But you really have to listen to the patient to get that.
So this is kind of there's a question that I got, which is, so how do the patients come to you, and do they should if somebody is talking to their man, should they go to their primary care doctor? Should they say, I think you should go see a urologist? Like where do they start, and at what point?
You can go to the primary care doctor. Many of them are very comfortable at handling erectile dysfunction. I don't think they do as much of a workup with labs and hormones and monitoring that the urologist does. I think we probably take it to the next level. But I think they're all very comfortable prescribing the medications and at least giving the patient some trials of those medications. And if that doesn't work, then it's definitely time to see the urologist.
Okay. So that's something that they should.
That being said, there's a lot of these websites right now that are, those apps like the Roman app where they can log on, they can see the doctor, and then they'll send them like the Viagra or the Levitra. And that in my mind is like the primary care model, right? Like they're going to try the medication, and if that doesn't work, then they're going to come see me.
So are there risks of just doing one of those, the apps that you're talking about, and just trying Cialis or Viagra? Like what do you need to think about before you're like, let's just try the blue pill for a weekend?
Right. The problem I have with the apps is they don't check all the appropriate blood work. And so maybe someone's primary care doctor has checked PSA for prostate cancer, and maybe they've checked their triglycerides and all that stuff. But the problem with the apps is that they're not checking the other stuff and the hormones to make sure they're okay. They're just asking you some questions and then sending you the medication.
Okay. So
it's not really a complete workup.
Yeah, which is always the stickler on that, isn't it?
Right.
Okay. So again, please send me more questions because those are great. I love the questions coming in. So here's a myth. It's kind of, you talked a little bit about the prostate. Can you talk about prostate screening? Because this is like, we're all talking about like our sexual wellness and with partners, and like, so does surgery on the prostate always cause impotence?
Yeah, that is a very common myth. So most people don't even know how the prostate works. So the prostate.
So give us a physiology and anatomy. Where is the prostate? Why is it connected to the penis?
So the prostate is connected to the bladder, and the urethra, the P channel, as I call it, runs through the prostate and out the penis. So you have the bladder, the prostate, and then the urethra goes through the center of the prostate. So the prostate releases enzymes to help make the semen fluid, to make it more liquid. So I tell patients, you make sperm in your testicles. They go up through the tubes. They get what I call their backpacks from the seminal vesicles, which is their glucose and their nutrition. And then they head off through the prostate, out the penis, off to duty. So in order for that fluid to be really liquid, that's what the prostate does. It makes the enzymes that do that. So for prostate cancer, you want to have the screening blood test. And more we're now associating patients that have had moms with a history of breast cancer, dads with a history of prostate cancer, or maybe your aunt or your grandma with a history of breast cancer. Those patients should be getting screened for prostate cancer. And remember, the screening is a blood test. It's just a simple blood test for PSA. The American Medical Association will tell you that you should start at 50. Most urologists will screen patients probably starting at about 40 or 45, depending on their history.
Excellent.
So going into your second part of your question, which is surgery. So there's different types of surgeries for your prostate. Now, many men have an enlarged prostate, which does not mean that you have cancer. I see lots of patients with very big prostates that have trouble peeing that have no cancer, and I have patients with very small prostates that are full of cancer. So if you have a big prostate and no cancer, you might have trouble peeing. So a doctor may recommend doing a procedure on you, something we call a Roto-Rooter, where we help open up the pee channel and let you pee better. And that does not cause erectile dysfunction. Very, very low incidence, probably less than 1 or 2%, because you're not going near the nerves of the prostate. You're just kind of coring out the center of the orange to open up the channel so that the pee can come out. Now, patients who have prostate cancer may have a surgery called a robotic prostatectomy. In that surgery, the surgeon has to pull the prostate away from the nerves and out of the body. When those nerves get touched, when they get damaged, if they get cut, that can affect your erectile function. So oftentimes patients will come to me for urinary symptoms, and they will need a procedure to help with the urinary symptoms, and they're so worried about erectile dysfunction. That's not what causes the erectile dysfunction. It's the bigger prostate cancer surgery that can cause erectile dysfunction unless it's done in the right hands.
Super interesting. Like, I love this. I love like learning about the physiology. I mean, I did learn it once in medical school, but I know that I'm getting lots of comments that everyone loves this. I especially loved your visual of like, they grab their backpacks, they're going through, this is like how all of that anatomy works. And I think it's so important for us to understand how that anatomy works, especially as everything is changing there. Okay, so we've got a couple of questions. I'm gonna read through this first one because it's a little complicated. So it's about vitamin B12 deficiency causing nerve damage. So can vitamin B12 mask a B12 deficiency? Does Dr. Linehan know of any erectile dysfunction patients who suffered nerve damage associated from B12 deficiency as an underlying cause of erectile dysfunction?
No, I haven't had any erectile dysfunction specifically, but that being said, I have seen patients that have difficulty urinating or urinary retention because of B12 deficiency. And a lot of those nerves are actually intertwined. So when I have a patient and they have really an unknown cause of why they can't pee, it's actually one of the things that we do check, and it can be helped. So I think it's theoretically possible that that could also affect erectile dysfunction, but it's not one of the things that we typically check for. That's a very good question.
So, but that might be part of that initial workup, which is nutrition, including all the things that can clog your arteries.
Correct.
The little ones to the penis and the big ones to the heart, or the bigger ones to the heart. So when you've had the prostate removed, does everyone go on hormone replacement? And does estrogen hormone affect the ability to get an erection?
So it's two separate questions. So the prostate doesn't really release any hormones. Testosterone comes from your testicles. So if you remove the prostate, you don't necessarily have to go on hormone replacement, but we do follow your hormones to see if your testosterone levels are normal. with estrogen, you do have some men that make too much estrogen, which can affect their libido. And so, in the workup that we do initially with all the hormones, we look for estrogen levels, testosterone levels, and the hormones that come from your brain that encourage your testicles to make those hormones, to see if those are all normal. Now, if a patient does have elevated estrogen, if a man has elevated estrogen, then there are medications we can use separately to help decrease the estrogen levels, which again helps to encourage the libido and testosterone formation. So I think that that's what that patient was asking.
I think so. They were saying that their husband had his prostate removed and is on estrogen hormones.
So, okay, that's if someone has their prostate removed for cancer, and the cancer comes back, sometimes the prostate cancer, sometimes we give them estrogen hormones to basically stop the growth of the cancer. So that's more specific around cancer.
Okay.
There's two ways the estrogen works for men. It usually doesn't help them.
Gotcha. Okay, so here's another one, and this is definitely about women's wellness. What if your man gets up to pee several times a night?
So we call that nocturia, or nighttime urination. And that is actually one of the questions that I ask very frequently to see if the patient has prostate issues. So, does the man have weak stream? When they go pee, is the stream weak? I'll ask, can you hit the back of the toilet when you pee? Some guys will say no. Does your stream start and stop? That's called intermittent stream. Does it take you a while to get your stream started? Meaning you get up in the middle of the night, you really have to go pee, and you're standing over the toilet waiting and waiting and waiting. Or getting up frequently at night could mean that there's some prostate issues, and definitely best to talk to your urologist about that, and he may need to be started on some medication that can help. And I do see couples that come in and, because he's getting up at night, or sometimes it's she's getting up at night to go pee too, they're waking each other up and nobody's sleeping. So it can be really disruptive.
Is that nocturia caused by prostatic hypertrophy? What are the treatment options, or is the workup always to go to a urologist first, or can you go to your primary care doctor?
Nocturia can be really difficult to treat. So I actually recommend going to see a urologist because some patients, the first thing I always start with is behavior modification. If you're drinking 3 glasses of wine a night before you go to bed and you're getting up 5 times to go pee, yeah, that might be why you're getting up to go pee. And so we do some behavior modification and say, okay, let's stop drinking at like 6 before we go to bed and see if that still happens. Now, if that still happens, maybe it is due to an enlarged prostate that's not necessarily cancer. It's just benign disease, a benign growth of the prostate, and medications may help that. And in some patients, they actually can have even men and women can have an overactive bladder. It means the bladder is spasming at night, not allowing you to sleep, telling your brain I have to go pee when it's not the appropriate time to go pee. So sometimes I have to treat this with medications to calm the bladder down. So it could be a variety of things. And often I may not know when the patient comes in what it is. It might be trial and error for both of us until we figure out, is it your prostate? Is it your bladder? Is it your habits?
Okay.
There's only one medication on the market for both men and women for nighttime urination. And it's actually desmopressin. It's probably a hormone we all know. It's the same medication we use in kids who wet the bed. And so if you take this medication at night before you go to bed, you actually make less pee during the night and more pee during the morning, which helps you go less at nighttime. So a lot of different options for nocturia, which is why I recommend seeing a urologist for that, because it can be caused by many reasons.
Excellent. That's awesome. So we have 20 more minutes. I have a bunch of questions, but I just want to quickly go over, because we have 6 more scheduled that are on a weekly, and then we're going to go to every other week. So I just want to put this out there because people are putting in questions. I also want to hear if you have other specialists you want to hear from. But next week, we're going to have Dr. Verna Porter talking about cognitive health and Alzheimer's disease. The following week is Dr. Nicole Weinberg, a cardiologist, so talking about women's cardiac health. Then Dr. Lisa Vidito, an anesthesiologist, talking about kind of all the myths around anesthesia and what happens if you have multiple surgeries and what if you don't wake up, all of that. Then Dr. Adriana Schmidt, who is a dermatologist, so we'll talk about some skin cancer and skincare. Dr. Claudia San Miguel, and I had several requests for talks about IBS and SIBO and kind of all things gastrointestinal health. And then we'll have Kimberly Childers, who did genetic counselor, talking about genetics. And then Dr. Barbara Gieser talking about multiple sclerosis and risks and treatment in women. So that's kind of the lineup. I'm going to put that on the Facebook page so that you can go and kind of see and schedule that out. But so you were just talking about, now we're getting back to Dr. Linehan, so that there is a connection between prostate cancer in men whose mother had breast cancer. Is the reverse true? So if a woman's father had prostate cancer, is there a connection with breast cancer? I guess the question is, what's the connection between the prostate cancer and the breast cancer?
So we found more and more relations.
This is so interesting. Prostate cancer and cancer in women.
Thank you. I'm so glad.
Thank you. So there is a connection between the same hormones and the same genes that that cause patients to get breast cancer as well as prostate cancer. So yes, the reverse can be true. So now we ask patients, I never used to ask patients who I was screening for prostate cancer about their moms. I always asked about, well, did your dad have it? Did your uncle? Did your brother? But now I'm asking patients, did your mom have breast cancer? Did your auntie have breast cancer? Because we know that's related to prostate. And those should be the same questions that the breast surgeons are also asking of women. Did anyone in your family have other related hormone cancers? Even ovarian and uterine fall into that category too, but really prostate and breast tend to be related. And we know that patients that we know in prostate cancer, patients with prostate cancer that had relatives that have breast cancer are at higher risk.
Fascinating. So again, that's kind of either being with a specialist or getting in to see a geneticist. And maybe when Kimberly Childers comes on in a few weeks, we'll ask her about this. Yeah. And what's there. So can you talk about kind of, there was a question about what clinical trials or what like new research is out there about erectile dysfunction or urology? Like what are the exciting things that are coming up right now in your field?
So one of the most recent technologies that urologists have really been focusing on is ultrasound vibration technology. And we've used it for years in patients who are paraplegic. So they actually will take vibratory, and sometimes it's a stimulator or a vibration, and they'll use it to help get erections into the penis. Well, taking that kind of theory that works, we started looking at shockwave technology for patients who had erectile dysfunction. So you can go into the doctor's office, and actually my partner, Dr. Mayron Movasagi, does this. And it's a ultrasound kind of shockwave technology, and it's a small wand. It doesn't hurt. Patients always ask me if it's painful, and it's not painful, but they do this kind of shockwave ultrasound technology along the penis and along the corpora to kind of help open things up and regenerate and re-stimulate the blood flow to the penis. And there has been some studies that show it's very, very effective. And we are probably going to be starting a trial for prostate cancer patients where we're doing the ultrasound shockwave therapy before and after prostate cancer surgery to see if it helps and enhance erections. The other technology, people are doing PRP, which is platelet injections into the penis. I have seen patients get some good results with that. But I really think the newest thing that's showing the most promise right now is the shockwave ultrasound technology.
Awesome. Super interesting. Like that's fascinating. And I'm excited that you guys are going to be involved in some of that. So I have a question going back to women, although this is super helpful. I feel like this is such good information for women to have. One, because they probably notice it, but also direct a lot of the healthcare in the home. And so it's great to have this information and be able to help everyone, girlfriends, men in your life, all of that. But there's a question about UTIs in women And why do we get so many more as we age? Why does that happen?
So UTIs in women, so let me start here. Most women get 1 to 2 urinary tract infections a year. Part of that reason is that our urethra is relatively short. So it's a very short course for bacteria to travel up into our bladder and start an infection. Now, this is probably happening all the time to us. Luckily, we have this mechanism called peeing to get the bacteria out of the bladder. But sometimes the bacteria grow too fast and then we get a urinary tract infection. Now, when we're younger and still when we're older, sometimes that happens during sex, because during sex, the bacteria kind of get pushed into the urethra. And it's funny, patients always think it's the bacteria on the man, but sometimes it's not. It could be the bacteria that's actually in your own vagina that's getting pushed into your urethra and starting an infection. So it's typically why women get infections. Now, as we get older, your estrogen levels go down and your bladder loves estrogen. There's a lot of estrogen receptors in your bladder. And as the estrogen levels go down, your bladder doesn't have the same immune defenses to protect itself against the bacteria. There's actually changes that happen to the lining, the mucosal lining of your bladder, that leave it more open to getting infections. And women tend to get more infections that way. Also, the vagina starts to become drier, less lubricated, which also can allow the bacteria, that the skin can crack and allow the bacteria to get into the skin that way as well and predispose women to have infections. There's also women who are genetically going to get infections because they have receptors that they were born with on the lining of their bladder that bind to the bacteria and snatch it and hold on to it. Now, there are things you can do to block those receptors from binding the bacteria. That's cranberry. It's why people recommend cranberry all the time. And I always tell patients, you would have to drink so much cranberry juice to get the effect, which is why you really need to take a pill. And you have to take the pills multiple times a day because they need to stay in your urine. So cranberry is one and D-mannose is the other. D-mannose is a powder. I like the powder form of it. And you have to put a tablespoon or 2 in your water a couple times a day, morning, noon, and night, to help, again, prevent the bacteria from binding onto the bladder. And I mean, I've really had patients have great results with the cranberry and with the D-mannose to kind of shed the bacteria off the bladder into the pee and get rid of the infections.
Wow, great information. I am loving this. This is awesome. Okay, so we have 10 minutes left. Here's a question. You get to pick either a question about STDs, herpes, or interstitial cystitis.
We don't either. We have time for both. What's the question about interstitial cystitis? Because this is a very common.
So I guess that is kind of the question, like, what is it and why? Is it becoming more common, or did we just not know about it before?
So interstitial cystitis to me is what I call a garbage can diagnosis. That means that the patient, I have ruled out every other cause for bladder pain, for urgency and frequency of urination in the patient, and I can't find anything else. Interstitial cystitis usually is severe urgency and frequency, difficulty holding urine. It's painful when they're holding their pee. It's painful when they're peeing. Everything about urination is painful. Now, that can happen for many reasons. One is infection. 2 could be hypersensitivity, meaning you could be eating or drinking something that's irritating the lining of your bladder that's causing those similar symptoms. Just like putting things on your skin, your bladder is also very sensitive. Sometimes those symptoms can be associated with cancer and they can be checked out. So if I usually go through a whole course of checking everything out in the patient, is it infections? Is it hypersensitivity? Is it just overactive bladder? Is it cancer? Making sure those aren't the causes. And then interstitial cystitis.
This is so interesting. Most of this has been about the prostate.
About that.
Well, I know, but they've done a lot of different things in prostate surgery.
If I can.
And one would be the fact that the surgery now can be where you still.
Okay. Go ahead.
So yeah, but I think what's has happened is that IC has become, people are reading about it more, and I see a lot of patients that come to my office and say, "Oh my gosh, I have IC," and I'm like, "You don't have IC. You had some bad infections. Your bladder's really inflamed, and it's going to get better." So I mean, the patients that I work with that have IC, I mean, they are in a lot of pain. I mean, these are patients that sometimes even require narcotics because the pain is so bad. And I will tell you, I'm a girl. I've had urinary tract infections. I know that that is one of the most noxious, awful feelings on the entire earth. You can't think about anything else, but I just need to go sit on the toilet and try to go pee again. So I do understand, but the diagnosis of IC is very specific, and it should not be something that you read on the internet and gave yourself. It should be something that the urologist gave you.
So again, the specialist. So I will make sure that we put Dr. Linehan's contact information onto the Facebook page so that anyone who does need to contact her can. Does peridium work? I think that's a question about the interstitial cystitis, and then I'm going to go back to the urinary tract infection.
IC is so uncomfortable that even sometimes things like peridium do not work for these patients because the lining is so distraught that the pyridium, which is basically like a Tylenol for the bladder, it's that medication that's azo that turns your urine bright orange. You can buy it over the counter, but for patients with IC, it doesn't often work. I have to try a variety of different kind of concoctions. Sometimes I have to put installations into patients with IC to calm down their bladder. But
okay.
And what I tell patients is most important. If you think you're getting a UTI, if you feel like you're getting a bladder infection, go buy the azo, try it for a couple of days. Azo is the over-the-counter version of pyridium, which is the bright orange medication. Like I said, it's like an analgesic for the bladder. It helps calm it, lessens the urgency and frequency. And after 2 or 3 days, if it's not working, you need to get a culture and you need to get checked for a bladder infection.
Excellent. Okay, so I'm going to backtrack quickly to the UTI one, which is any recommendations for a brand of, I think you talked about something instead of cranberry, or how much cranberry do you need to have it?
There's a couple different brands of pills. There's Eucora. The one that I really recommend for patients is Eucora, which is a 24-hour cranberry. Because remember, I told you if you don't take it all time points of the day, it's not going to stay in your pee all the time, and it's not going to work. It's not going to be functioning. I like the Allura because it's a 24-hour pill. You can buy it on myallura.com, and you take one. Huh?
Can you spell that? Allura?
I'm putting it in right now.
Thank you.
You take one pill every day, and you take 2 pills with sex. And I have patients that it works really well with. And again, remember, the cranberry blocks the bacteria from binding on your bladder. So you pee it out. It helps you just pee out the bladder, which is the normal way to get rid of bacteria.
Excellent. So I'm going to do the question about HPV, but first there was a comment about we need to have a discussion about the vagina as in depth as we did about the penis tonight. I totally agree. Those are coming up. Don't worry. We did have Dr. Kadish, which her recorded conversation is on the Facebook page for the Women's Health and Wellness Institute. So you can go there and listen to that, but we will definitely have more. Okay, so here's your HPV question. You ready?
Yeah.
So if the patient has an HPV vaccine, can you still get HPV if your partner has warts or is infected? Can you talk a little bit about that whole transmission?
You can still get, especially if the partner has active warts, you can still get HPV. You're much less likely to get the cancer associated form of the HPV, but you can still get the warts and the lesions from the HPV. Often the types of HPV that form the warts are not the ones that form the vaginal cancers and the rectal cancers. But yes, you still can get the warts with your partner.
But you're more likely to get the cancer causing type. So
you're more likely to get the wart causing type if the partner has the genital warts than the cancer causing type. The vaccine really helps protect you against the cancer causing part, but not always completely the wart part. Does that make sense?
Yes, absolutely. Absolutely. This was
another
I think I got through all of the questions. I hope that I did, but there's so many. Like, this was very interesting discussion. really, really great. Really appreciate your time and expertise. Do you have any, are there any myths that we didn't cover that you have? I feel like I dominated the whole conversation, but there was so much engagement.
No, I think we got all the ones that were on my list too.
I think we did. This was fantastic. Okay, so I'm going to put the information onto the Facebook page. And again, we really appreciate your time. It was a terrifically frank conversation and something that I think will help all of us, because sexual wellness is women's wellness.
That's right.
Absolutely.
Thank you very much.
All right, thank you so much. Have a good night, everyone.
Thank you.